So, Anna sir, senior colleagues, Hemant sir,
Yeah,
uh,
good evening, sir.
Happy New Year, everyone.
Yeah,
Uh,
Happy New Year, sir. Happy New
this is
Year.
the first class for the year, and I could see Ratna ma'am joining, Rajiv sir here, and other senior eminent faculty. Uh, so, we have two case presentations today. One is kindly contributed by uh, Dr. Can you try to mute children, please? So we have two presentations. Give me a minute, please. So I'm going to mute everyone. So I wish people who wish to speak, unmute yourself and speak. So I'm glad that we are able to continue this good work. Thanks to all the faculty and students who have made this a possibility. So we have tried to change the invitation design, and we will try to bring in some more new changes so that students get benefited. Today we have four eminent faculty. Professor Anandi ma'am, Professor of Surgery from Government Stanley Medical College. Professor Hemant Kumar sir, he is a Professor of Surgery from Himalayan Institute of Medical Sciences, Jolly Grant. Ratna ma'am is our regular faculty, has become so. Welcome ma'am. And a few of the faculty are expected to join. Dr. Rajavelu sir will be joining a tad late, he told. And I expect other students also join shortly. So warm welcome to all of you. So we have two cases. One is kindly contributed by Professor C.D. Narayanan sir, Dr. Rishabh. He'll be presenting a case of mass abdomen. The other candidate is kindly contributed by Professor T. Srinivasan, Coimbatore Medical College. She will be presenting a case of multinodular goiter. So as Dr. Muthwadiva has still some connectivity issues, I request Dr. Rishabh Ranawat to start sharing his PowerPoint and introduce himself, his unit chief, head of the department, and start your presentation. Faculty, please take over. Thank you. Good luck to you, Dr. Rishabh.
Thank you, sir. Good evening, everyone. I'm Dr. Rishabh Ranawat. I'm third year surgery PG from Sri Ramchandra Medical College, Chennai. And my guide and the head of department is Dr. Professor C.D. Narayanan. I'll be starting with my case. Chief complaints, a 54-year-old lady who's a homemaker by occupation came with the chief complaints of abdomen pain since 2 months and melena since 1 month. History of present illness. Patient was apparently all right 2 months ago when she complained of abdomen pain localizing to the right hypochondrium, insidious in onset, dull aching in nature, continuous, and it aggravated on food intake. It is a non-progressive type of pain. There's no history of radiation of pain, no effect of pain with movements or with respiration. Also, there's a history of melena since 1 month. It was associated with increased frequency of stools. She used to pass stools 3 times a day, which was semi-solid in nature. There's no history of any spurious diarrhea or tenesmus. There's no history of difficulty to pass stools. History of loss of appetite present. Previously, she was able to have 4 idlis. Now she can have only 2 idlis. Associated with loss of weight present, 10 kgs in around 2 months. There's history of weakness present. There's no history of fever, vomiting, hematemesis, no history of jaundice or pruritus, no history of back pain or sciatica type of pain, no history of chest pain, palpitations or dyspnea or cough, no history of hematuria or dysuria, no history of any previous blood transfusions, no history of headache. Past history, she had dyspeptic symptoms 6 months ago, for which she underwent UGScopy, which was normal. Along with that, she is a known case of systemic hypertension and she's on antihypertensives. Surgical history, she has undergone perpural sterilization 20 years ago. Personal history, she's had normal blood habits and she has a mixed diet. Menstrual history, she attained menopause at 46 years of age and menarche at 13 years of age. Obstetric history, she's a P2L2 with a normal vaginal delivery. Family history, there's no history of any similar illnesses in the immediate family members. Summarizing my history, a 54-year-old female who came with complaints of right hypochondrial pain and melena with a significant loss of weight and appetite, uh, along with comorbidities of systemic hypertension, probably is suffering from a growth of malignant etiology in hepatic flexure.
Yes, Dr. Rushabh.
Yes, ma'am.
You have started the case in your history of presenting illness by saying pain is localized to right hypochondrium. It'll be a good idea to use patient's language rather than using the term right hypo.
Okay,
Right?
ma'am.
Yeah. So what kind of pain was it? You said it's a continuous kind of a pain.
Yes, ma'am. It started
So
insidious and onset. It was continuous, not relieved on medications.
So from the history, do you think it was a visceral pain or do you think it was a parietal pain that she was talking about?
Visceral pain, ma'am, because it's a dull aching kind of pain. So I'm thinking visceral pain.
So what kind of, what would possibly be the cause of dull aching visceral pain?
Ma'am, in acute settings, it can be dilatation.
Yes, you are correct. So distension, continuous distension can lead to continuous dull aching kind of a pain,
yes,
right?
ma'am.
So what kind of radiation were you looking for in a continuous pain? After qualifying it as continuous, you're talking about radiation of pain. Can you tell me any pain which is continuous, dull aching, and radiating still? Unlikely, right?
No. Yes,
So you
ma'am.
have given history. Can you define Malina?
Melina, ma'am. Melina is the passing of black, tarry, foul-smelling stools.
Think to be added more.
Yeah.
Sorry, ma'am.
Anything you want to add to that? Any more adjectives?
Complete the definition of Malina.
Foul-smelling black, tarry stools.
Large
That's it.
volumes of
Large
foul-smelling black tarry stools that stick to the pan.
It will be very difficult to flush away from the plant.
Okay.
Something like a tar, road tar.
Okay, ma'am.
Dr. Ranawat?
Yes,
Hello. Yeah. What do you mean by non-progressive pain?
The pain is of continuous intensity. It is not increasing or decreasing in the intensity.
No, that is not progressive pain. Increasing, decreasing could be the colicky pain. It increases, then it decreases. Right?
Okay. Okay, sir.
So progressive pain means it's getting worse over the time. The intensity, it started with a dull aching or the mild pain, and over the weeks or months the pain becomes more severe.
Yes.
Right? That qualifies as the progressive pain, not the change in the intensity over a short duration time. Like sometimes it is mild, sometimes it is severe. Okay.
You said
Yes, sir. Yes, ma'am.
You said your pain is getting aggravated on food intake. But
Yes,
when you summarize, you said it's from the hepatic flexure. How do you link it? At this juncture, why you want to narrow down your diagnosis to hepatic flexure? What is the commonest hypochondrial pain with melena? What will you think of generally? Because this person doesn't give you any lower GI symptoms also.
So what are the causes of melena that you have tried to rule out in history is what ma'am is asking. You have narrowed down your diagnosis to only hepatic flexure. So what causes of melena have you ruled out in the history?
Ma'am, because there's no vomiting, I'm ruling out upper GI pathology, ma'am.
So then how you will correlate, Dr. Anawat, then hepatic flexure growth?
Because of the pain, sir, I'm thinking hepatic flexure
And you said melena. Is melena a feature of a hepatic flexure growth?
more towards melena should happen more in upper GI, sir.
So
Okay, when you have a
rarely,
duodenal ulcer or when you
yeah,
have a carcinoma of the stomach, where will the
right.
pain be?
Epigastric, ma'am.
Only in the epigastrium will have duodenal ulcer pain.
Epigastric and right hypochondria.
Then why are you not
Okay.
thinking in terms of an upper GI pathology initially to start
Yes.
with? What made
Why?
you think of a hepatic flexure?
And then you said in the history also patient had the upper GI endoscopy done previously. So you should think of stomach or the duodenal pathology because at that time maybe it was normal or there was initial dyspepsia or the complaints patient had the upper GI endoscopy done, right? It was done how many months back?
6 months back.
6 months back. So there is a history of gastric discomfort or whatever is there. Why you have directly jumped with the history of melena? Why did you think of first diagnosis as hepatic flexure growth? There is no history of constipation here.
Yes, sir.
Right?
Yes, sir.
So,
Because small
which
bowel or
kind
large
of
bowel obstruction will present as a constipation, one of the main complaints.
Yes, sir.
How is melena
which
produced?
pain
Digestion of hemoglobin, ma'am. Acid hematine forms. So
Okay, if it's a hepatic flexure growth, then
because the not challenging.
It can happen. Rarely it can happen. The small bowel or large bowel growth can present as a bleeding, can present as a melena because of intestinal bacteria digestion of the
Yes, sir.
arteries. That can cause, but that is not a classical presentation. So with melena, you should think of upper GI pathology first, not of the colonic
Yeah.
causes of the bleeding.
Yes, sir.
Right? And what other differential you will rule out? Like the patient gives you history of only a black stool, he will not say you tarry stool, and the foul cannot be definitely deduced that foul. Everybody has a foul stool. You know, the patient. So, what other history you will take from the patient to label this black colored stool as melena?
Any AV malformations?
No. Black colored stool.
History of
Did you ask did the
iron?
patient say it sticks to the pan?
No, I didn't ask that, sir.
So how did you label then it as a melena? It could be simply a black colored stool due to other causes, some drugs or some particular foods. What are those causes? Where the patient may give you a black colored history of a black colored stool.
Iron supplements, sir.
Yeah, iron supplementation, bismuth subsalicylates, too much consumption of beetroot. So you have to take this history from the patient before labeling the black colored stool as a melena.
Yes, sir.
Right?
Yes, sir.
then we move to the next slide.
Yeah, Dr. Hanawat.
Yes, sir.
In the first line, you said no history of tenesmus, right? If the pain is in the right upper abdomen or in the upper abdomen, what is the significance of this history of tenesmus?
Any, sir, if there are synchronous cancers
No,
in the rectum area, in the rectum, so tenesmus can happen. So,
no. The patient is only complaining of the pain in the upper abdomen. More specifically, you said right hypochondria. So what is the
yes, sir.
correlation? Why did you specifically ask tenesmus? It means for a patient with upper abdominal pain, you will think of the rectal malignancy. Rectal malignancy will have what are the main complaints in the rectal malignancy?
So altered bowel habits mainly.
One is altered bowel habit, yes. Other is bleeding per rectum.
Bleeding per rectum.
Then there could be spurious
What is the spurious diarrhea?
Ma'am, when patient wants to pass stools, instead of stools, only blood and mucus comes. The spurious diarrhea. Early morning spurious diarrhea.
Why does this happen?
Because of any mass in the rectum, the mucus will accumulate above the mass. So that mucus, along with the blood, because of the ulceroproliferative growth, the mucus and blood that causes the spurious diarrhea. Instead of stools, patient will just pass mucus and blood.
Actually, there is a stercoral enteritis which happens there. The localized bacteria which is causing this reaction, which makes the stools into a liquid form, and this will result in a spurious diarrhea.
Okay.
So you consider this loss of weight to be significant?
Yes, ma'am. 10 kgs in 2 months.
How did you ask the patient? Did the patient know her weight 2 months
Yes,
back?
sir. Yes, sir. Before she knew the weight, sir.
She knew her. So how you will confirm if the patient is a illiterate, a villager from a rural background, they don't know their actual weight. So how you will elicit this history?
We'll ask if the clothes are loosening, sir.
Yeah, loosening of the clothes. Okay, right. And second, you have written 1 point, no history of backache and sciatica. What is the correlation with these complaints? And you have specifically asked sciatica.
Sir, any spinal metastasis can cause back pain, sir. But
where is the common metastasis of correlation?
Sir, it won't metastasize to bones.
So you don't have to take each and every step, because if you have taken this history of back pain in the breast carcinoma, it is okay. Even back pain is okay. But specifically taking a history of sciatica pain is not mainly due to this metastasis. And the metastasis of colonic malignancy is where it goes.
And again, why hematuria?
Liver.
Liver, yes.
Because I was thinking in the pain was in the right upper quadrant. So any mass from
you said there is a melena, then why you still think in terms of a renal pathology there?
Yes.
Okay, we'll move on to the next.
Dr. Ranawat, this is Dr. Sahai.
Yes, sir.
Look, first of all, your history is like an MBBS student. It should be more like a surgeon. You've taken up everything which is right, left, and center.
Yeah.
Also, a patient with pain, upper abdomen, with melena, I will think of peptic ulcer syndrome, even if there's weight loss. In gastric ulcers, there's weight loss. In duodenal ulcer, there's weight gain. So why are you thinking of a hepatic flexure? I mean, really focused on hepatic flexure malignancy with just pain upper abdomen with peptic ulcer syndrome, could be peptic, with pain, with melena. Think of the commoner things, isn't it?
Yes, sir.
You said history of weakness is present. What did you want to communicate? What is this?
Because melena is there, so loss of hemoglobin.
Anemia, you want to
weakness was there?
Anemia. Yes, ma'am. Anemia, ma'am.
Huh? No. What did you want to communicate by saying what exactly was the patient having?
Fatigue, ma'am. She was having dizziness while doing basic activities, ma'am. So
you should be more specific. It's a very vague term, not recommended to use. If she was breathless, you have to talk about that. If she had fainting attacks, you have to talk about that.
Yes,
and then you could have justified your answer of hematuria by saying you were trying to rule out a bleeding diathesis or something, What are the causes of melena?
Ma'am, upper GI pathology, any bleeding peptic ulcer can cause melena, ma'am. After that, AV malformations can cause melena.
AV malformations where?
I mean the upper GI, duodenum.
Can you tell me some non-bowel cause for melena? It can even cause massive bleeding per rectum at times.
Ma'am, aortoenteric fistulas, ma'am.
Okay. Yeah, that will cause frank bleeding per rectum and patient will be in shock. There will be no melena. Yeah.
And Meckel's, bleeding Meckel's.
Okay. What is bleeding in the bleeding Meckel's is bowel, no? I asked you non-bowel cause for. Can you get bleeding in
Esophageal
the
varices.
huh?
Bleeding in the
Common bile duct from anywhere?
yes, ma'am.
Right?
Yes, ma'am.
Okay, move to the next slide.
Okay, yeah, one more. Dr. Anawat, you asked
Yes, sir.
no history of jaundice, and then you asked pruritus. Why did you ask the history of pruritus? If there is
Sir,
no history of jaundice, if there would have been jaundice, then it is okay. You have to take the history of pruritus or itching. But there is no history of jaundice.
That is what I've been trying to tell him. You can't take everything positive and negative for every aspect.
Yes.
Also,
Okay, sir.
the best way to take your history is after you take your history, get to a differential and then ask by your history, try and rule out each of the differentials.
Yes, sir.
Right? So what are your differentials? You just given us a diagnosis. What's your differential? So look,
sir,
the patient is a 54-year lady with weight loss, with melena, with pain, upper abdomen, and nothing else.
Yes, sir.
Right. So how now tell us the differentials.
Sir, right upper quadrant pain can cause, can be due to any polydocholithiasis.
No. Hang on. Yeah, we have to relate melena, upper abdominal pain, and weight loss. You got a big hint from Dr. Ratna, which was one of the look, the most common would
bleeding
be
diathesis. Sir.
No.
What is hemophilia? What is hemophilia?
Sir, blood in the bile, sir.
Why are you not thinking in terms of a malignant gastric ulcer?
The second would be peptic ulcer syndrome. The third would be gastric. Look, gastric carcinoma. The biggest way of presenting is silent.
Yes, sir.
Right? It's silent. So you can just have pain and melena and nothing else.
And weight loss.
Yeah. So
Yes, sir.
so I don't know whether you've worked backwards that the patient's already got hepatic flexure malignancy. That's why. But keep your mind open. Okay, in an exam.
Yes, sir.
Yeah, you don't give us positives. You can't look. You've added chest pain, palpitation, dyspnea, and cough. You have added backache and sciatic pain. Look, you can't club malignant or metastatic symptoms with just
palpitations. Yeah,
you can't do that. Okay, take history
Yes,
of meds separately. Take history of whatever is of the symptoms separately. Don't club them together. Okay, you shuffle the whole thing
Yes.
up. And that
Yes,
makes our mind go right, left, all the time. Okay?
Yes, sir.
Right. Should we proceed?
By the way, what is Sandblum's triad?
Sorry?
Sandblum's triad.
I'm not sure. No, I don't know.
When you have an obstructive jaundice with a melena and a biliary colic together, it's called as a Sandblum's triad. So when you have a melena, it might be also due to some obstructive jaundice, it might be there. There might be a bleed which is happening, and it can also present as a melena. Right? If your patient
Okay.
has right. Go to next slide.
What is this no history of similar illness in family members?
Any immediate family
What are
members
you
didn't
trying
have.
to communicate? See, exam is all about communicating to the
Yes, ma'am.
examiner that you know what you are
Hmm.
saying. What do you
Yes,
want to
ma'am.
communicate by saying no history of similar illness in the family? You mean to say nobody in the family had melena ever, or nobody in the family had pain abdomen ever? What are you trying to tell?
This constellation of symptoms. Since
I
I was
think what
thinking
you're trying
in
to tell us is
No.
that nobody in the family suffered from any malignancy, bowel malignancy,
yes, ma'am.
right?
Yes,
Or
ma'am.
is it
Malignancy. No
Ah.
similar malignancy history in family members. That's what I was trying to
to be
tell.
clear about what you're trying to
Yes.
tell?
Right.
Yes,
Don't
ma'am.
write similar illness. Similar illness means sometimes benign diseases with the same symptoms.
Yes, sir.
Right. So be specific. No history of malignancy in the family or the no history, colony history. Right.
Yes, sir.
Okay.
Proceeds to examination.
General examination. Patient was afebrile, pulse 90 per minute, BP 100 by 60, and respiratory rate 12 per minute. Pallor was present. There's no cyanosis, clubbing, lymphadenopathy, pitting edema, or icterus. The ECOG score was 0. There was no signs of dehydration, and BMI was 21.
Ranawat, you like no cyanosis, clubbing, lymphadenopathy. And they should be in order. Like when you see pallor, you simultaneously see the icterus. Right?
Yes, sir.
So these should comment on the pallor and icterus should be simultaneous. Not after seeing clubbing, lymphadenopathy, then you again go to see the icterus.
Yes,
Okay?
sir.
So it will
Yes, sir.
the proper order when you
Yes, sir.
examine this. Usually edema comes first. Lymphadenopathy is the last part of that if you are examining the general examination, because you have to
Yes,
do
sir.
a detailed examination for that.
What is the
Yes.
nutritional status of this patient?
Sorry, what, ma'am? Sorry.
What is the nutritional status of this patient?
She's moderately built, ma'am.
No. What is the difference between built and nutrition? What do you understand by built and what do you understand by nutrition?
The nutrition as in the diet she's taking.
No, we're not talking about diet. What is her nutritional status?
Whether her appetite is normal. So
No.
her appetite has been decreased.
No, see, when we talk about the build, we talk about the height and the span of arms, the ratio of these two. That tells you about the
Okay.
build, the skeletal build or the framework of the patient. When you talk about nutritional status, you talk about the status of micronutrients. She's pale. She cannot be moderately nourished. No, she's poorly nourished. She's pale.
What are,
Yes, ma'am.
what are the
Right?
other things you look
And
for?
other
if
things that
there's-
you will look for will be, we
apart
don't know
from
whether she,
anemia?
Whenever you look for a pallor, okay, if a patient is pale, definitely the patient would be malnourished. That might be a poorly nourished candidate. So try to look for the nourishment status. The triceps,
Okay,
full
ma'am.
thickness, and other things. Okay.
You have seen the pitting edema, that another sign of malnourishment. What are the other things you will look for apart from pallor and pitting edema? To assess the nutritional
glossitis,
status of glossitis, okay. Oh,
chelosis,
okay.
skin turgor, and
Yeah, first you have to see the dehydration status also, no? Skin turgor, skin elasticity. Then
moistness of the mucosa as well.
that will dehydration. Then what you will look in the hair, the nails,
Loss of shininess, loss of
coarse hairs, grayish, or
coarse.
the patient will give you a history that a graying of hair has happened. Then ridges, thin, friable nails, that is koilonychia.
Yes, sir.
These are the signs of malnourishment, right? So
Yes,
you
sir.
have to see all these things for giving if the patient, you are labeling him as a malnourished patient. Okay?
Yes.
You've said no lymphadenopathy. How do you know no lymph node in the whole body is enlarged? Are we talking
Ma'am,
about any regional generalized or what? What is generalized lymphadenopathy?
when more than 2 groups of lymph nodes are involved,
In more than 2 non-contiguous groups.
non-contiguous.
To be specific about what we are talking about.
Yes, ma'am.
Yeah, proceed ahead. Can you, by looking at pitting edema, say what is the extent of edema? Where did you look for pitting edema in this
And
patient?
bilateral lower limbs, ma'am.
So does it tell you, does the extent of, how do you say whether a patient has got generalized anasarca or, only bilateral lower limb pitting edema due to some other cause?
And there's edema of the genitals and
No, it's not that. You have to look for the extent of edema over the leg first. And if edema is present over the arms also, as well as on the face, then you say the patient has got generalized anasarca, right? So it tells you about the extent of fluid. A general physical examination, you have to be thorough with it. Let's proceed to regional examination.
and per abdomen examination, umbilicus was in midline, inverted. All quadrants were rising equally with respiration. There's a purpural scar
This is
present.
such a big distractor right in the beginning. Umbilicus in midline. Did you expect it to be deviated in any particular direction or what?
No, uh,
Okay,
no,
go
ma'am.
ahead. Please complete. Please complete the examination. Yeah.
No dilated veins, sinuses, and hernial orifices were free, and the left supraclavicular fossa was free.
The inspection is complete.
Dilated sinuses, there are
Yeah.
distractors. What are these sinuses?
Why?
What
Sinuses
sinuses
are
did you expect there?
What do you expect in a patient with these complaints? Do you expect normally or even uncommonly a patient of right upper abdomen pain with melena, they have a high chances of having sinuses in the abdomen?
no, sir.
Then why you should not take these unnecessary points, right? Another you have written hernial orifice is free. What do you mean by free?
Sir, cough impulse was negative, sir.
You can simply say there is no apparent swelling at the hernial orifices or there is no bulge on the cuff impulse. Free does not mean anything. No?
Each
Yes, sir.
sentence needs to be rephrased, all quadrants rising equally with respiration.
Yeah.
Is there any rise and fall? You just need to say that they're moving equally.
Moving, yes.
Yeah.
Okay,
What
sir.
is this puerperal scar? Earlier you said purpural sterilization. You could have called it postpartum sterilization. Now, what is this puerperal scar present? Where was it present? Are you talking about a lower? What kind of scar? As a surgeon, we expect you to describe it, no? That a lower midline, upper midline, midline. What was present? What is this
So, ma'am,
puerperal scar present?
lower midline, small lower midline scar was present.
That's how you are supposed to be writing it, right? You need to rephrase each sentence on this slide.
Yes, ma'am.
Okay,
Dr.
Dr.
Anand?
Anand,
Yes, sir.
what
Yes,
do
sir.
you mean by purpural? What is exactly purpural?
Within 6 weeks of delivery, sir.
Uh-huh. Excuse me?
Within 6 weeks of delivery.
Okay. So where she could have had a scar after delivery also.
No,
It is
she
purpural.
underwent the sterilization.
So that
So
is
you-
not a puerperal scar,
That is
no?
not, yeah.
Okay. Okay, sir.
Don't look like Dekho, Ranawat.
Yes, sir.
Use words which are acceptable everywhere.
Yes, sir.
This, I think, in my 30 years, the first time I'm hearing of a purpural scar.
Yes, sir.
Right?
Sorry, sir. Sorry, sir.
Yeah. If you want to draw attention to yourself, fine. But then some smart Alex is gonna pull your tail using purpura.
Yes, sir.
Right?
Sorry,
Yeah.
sir.
There was no findings in the right hypochondrium, any fullness or anything.
No fullness noted.
No.
What was the shape of the abdomen, by the way?
Scaphoid, ma'am.
Was the abdomen
It is
flat
clear.
completely, or it was distended locally? How was the
No,
abdomen feeling? Like,
ma'am,
uh,
it was not distended. It was scaphoid. The shape of the abdomen was scaphoid.
Another thing, Ranawat, Dr. Ranawat, give us positive findings. These no dilated vein sinuses, they mean nothing. When you're sitting in an OPD and you see a patient with pain upper abdomen, right? What do you look for? Is there a visible lump?
No visible lumps.
So say that.
Yes, sir.
That is a positive a thing which I'm looking for, right?
Yes, sir.
I'm
Yes,
not
sir.
looking for dilated veins and sinuses. You've not mentioned anything in your history telling us whether the patient has portal hypertension or not, right?
Yes, sir.
So now, doctor, you said no dilated veins. Supposing there were dilated veins, which dilated veins in the abdomen would have been significant with respect to history of bleeding per rectum or melena?
Uh, Periumbilical veins, no?
Why?
Because their signs, they're the sites of photosystemic anastomos.
Yes. So how does portal hypertension cause melena? Causes bleeding PR, of course, but can it cause melena also?
Because of esophageal varices, ruptured, bleeding esophageal varices.
Bleeding esophageal varices will cause hemetemesis, massive hemetemesis, followed by melena. It can cause portal cecopathy also. Let's not get diverted. Let's move on to the next slide. Please move on to the next slide.
On palpation, the abdomen was soft. It was tender in the right upper quadrant. A vague mass was palpable, which was 4 centimeter from the costal margin. It is firm in consistency with smooth surface. Margins could not be appreciated. Fingers could be insinuated between the mass and the costal margin. There is no local rise of temperature. The mass was moving with respiration. It was non-ballotable. It was intra-abdominal and it was non-pulsatile, and there is no other masses palpable elsewhere.
Complete the examination.
There is no renal angle tenderness, no spinal tenderness, and supraclavicular lymph nodes were not palpable. On percussion, the liver span was 10 centimeter. There was dullness noted of 4 centimeter below costal margin along the mid-clavicular line. Other regions were resonant. Auscultation, there's no bruit over the mass, and bowel sounds were heard. Per rectal examination, it was normal tone. It was stool stained, and there no deposits.
Yeah, complete.
Yeah, good.
Go on.
No.
What is this? Why do you think is the right hypochondrium tender?
Ma'am,
You mentioned tender in
it
right
was
upper quadrant. We don't know whether the mass that you are palpating is tender or not. Is the mass tender or is there tenderness in the whole right hypochondrium?
in the right hypochondrium, ma'am.
The whole right hypochondrium is tender and the mass itself? Is there any
Mass
tenderness?
also, yes, ma'am. Mass also tender.
What about rebound tenderness? Is it present?
No rebound tender.
There is no
No rebound.
no localized guarding also?
No localized garden.
You should mention all that when you talk about tenderness. What do you
Yes,
mean by vague mass is palpable? What do you think is this mass?
ma'am, it was. I could not appreciate the margins. That's why I'm saying vague mass. It was a vague mass. It was
So
firm, ma'am.
usually, do malignant lumps have a well-defined margin or a vague margin?
Well defined. Should have.
So vague margin does not go in favor of malignancy. So
Yes,
what do you
ma'am.
think is this lump? From which organ do you think is this lump arising and why?
It cannot be from liver or gallbladder because I could insinuate my fingers.
It's moving with respiration. It is moving with respiration. Liver gallbladder
Yes.
is ruling out because even though it's moving with respiration. How can he rule out liver gallbladder if moves with respiration?
Yes,
Do
sir, I could.
liver
Yeah, liver and GB masses can move, sir.
But then you said
Cannot.
fingers can be insinuated between the mass and the costal margin. How can it be liver when you can insinuate?
Dr. Ranawat, Dr. Ranawat, Dr.
Yes, sir.
Ranawat. Yeah, just gather your thoughts. Tell us, okay, you've done your examination.
Yes, sir.
What do you think it is?
So, hepatic flexure growth, sir.
You're still stuck with hepatic flexure. Okay, tell us the characteristics of hepatic flexure growth on examination.
Mass should be palpable, sir. It should be
okay. All what is the difference between a right-sided colon growth and a left-sided colon growth?
Sir, right colonic growth can grow to a larger size, and because the diameter of right colon is more than the left, sir, and the left colonic growth will have more chances of
Good.
obstruction.
Now, such a large hepatic flexure growth, will it produce obstruction or not?
At later stages, it can produce.
So you think it goes outwards and then later goes in towards the lumen, or the other way?
It should grow outwards, sir.
Okay. Now, what are the other characteristics of a hepatic flexure growth? Will it move with respiration?
It should move, sir.
It should move. So why does it move with respiration?
Because it is an intraperitoneal organ, sir.
No.
All
intraperitoneal, yeah.
Are all intraperitoneal organs moving with respiration? Okay. Is the hepatic flexure attached to the liver?
How is it attached to the liver? Hepatic flexure? What attaches it to liver?
Yeah.
And the transverse mesocolon.
Transverse mesocolon is present over the area of transverse colon. So there is this hepatocolic ligament, isn't it? That attaches it. So that gives it a minimal mobility. It's not a freely mobile structure. It gives it a minimal mobility.
Yes.
And
so do you think this lump was indentable or not?
No, ma'am, not indentable.
How do you say it is indentability? What do you mean by indentability?
I could see pitting over the mass as.
So can bowel masses ever show indentability? And if it is present, what does it indicate?
As in loaded stools can show indentability.
So there was no indentability here. So you feel this was a mass itself and not a mass of equolates, right?
What was the extent of your mass?
Ma'am, I could not define the margins, ma'am. So.
No, you did a ballotable test, no? How did you do it in the right hypochondral swelling?
Ma'am, one finger. As in ballotability means one palm should be behind the loin and one.
No. What madam is saying is right hypochondrium has a bony structure at the back, no? So how did you elicit ballotability?
Ballotability is to see in the flank masses, not in the right hypochondrial masses or right upper abdomen.
Okay.
Dr. If a lump is bimanually palpable, or you can palpate it with both the hands, then you have to go in for a ballotment, right?
Okay, sir.
You can palpate it from above and palpate it from below, and not simultaneously, and then you push it, right?
Yes.
So,
Ballotable, that means your mass is coming down almost up to the lumbar region. That
Yes,
is what
sir.
I am inferring.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
But still
Understood.
you're not able to define the mass and you're not able to give the measurement for your mass. Then such a big one. You can say some
Ma'am,
dimensions at least, though it might be a vague one. Roughly one diameter can be said.
ma'am, then 3 by 2 centimeter, ma'am.
3 by 2, but how did it reach from hypochondrium to lumbar region?
Ma'am, then my
3 by 2
biology
is
is
as
wrong,
big
ma'am.
as the distal phalanx. Will you be able to palpate a 3 by 2 centimeter lump? Your distal phalanx must be about 2.5 centimeters, no?
Yes,
Is
ma'am.
the lump as small as that?
No, not as small, but
You've not measured the size of the lump.
no, ma'am, I could not margins. I could not clear margins. I could not appreciate. That's why.
Okay, we go by your findings. And how
Okay,
will you?
right. I just want to ask another thing, Dr. Ranawat. What's the normal
Yes,
liver
sir.
span? Just go back to your palpation. You said something about liver span. Or was it a liver span? You said something about liver span. Yeah, 10 centimeters. So what's the normal liver span?
In mid clavicular line, it should be 9 to 11 centimeters.
Is it?
No, you're incorrect.
Is it?
In the
And usually the liver span is between 12 to 15, right? In mid clavicular line. And that would be covering your hepatic flexure of lump of 3 into 2 centimeters.
okay, sir.
Okay.
The
Chalo, go
percussion
on.
note over your mass. You said other regions are resonant. What about the percussion mass on your note on your mass? Which has not been mentioned.
Ma'am, dull sound.
Stony dull?
Yes, ma'am.
Then why is it bowel mass if it is dull?
Stony dull.
You're calling it a bowel mass and then you're saying it is dull on percussion and it is not a fecalith.
Because of the
dull?
history, I
History
was
doesn't
thinking
have
of a
anything
growth.
to do with percussion, no?
Yes, ma'am. It is a firm mass. That's why I thought it could. It was as in dull aching, dull.
Is there any free fluid in the abdomen? Show us
No,
what
no,
have you
ma'am.
written about the free fluid?
I have not written anything.
Why not? You're talking of malignancy and you're not talking about free fluid in the abdomen. Why? So you should.
Dr. Ranawat, you're in first year or second year? Or
Final
third year?
year.
Final year. Okay.
When you percuss over a mass which is present in the bowel, what will happen? There is an underlying air inside. Okay.
Yes, sir. Yes,
so
ma'am.
definitely you will have a resonance, but that resonance will be little bit impaired. Okay.
Yes, ma'am.
So that is the thing you are supposed to say.
Right? Yes, ma'am.
When it's going to be fully occupied by a growth or a mass, right? Then it might be having an impaired dullness, not a stony dullness.
Yes, ma'am.
Right? Go ahead.
Yes, so how will you manage? Actually, you've got the findings also, tell us. How will you manage this case?
Yeah, one question, Dr. Ranawat. Ma'am, just one
Yes,
question. On the auscultation, you have no bruise over the mass. So what do you expect from which type of abdominal muscle will have a bruise? Or in this right upper abdomen, which type of mass do you expect that it will have a bruise on auscultation?
Not, sir. Aneurysms can present with
So do you think this is the site of the aneurysms, common aneurysms?
No, sir.
Or other way around, what swelling in the right upper abdomen can have a bruise on auscultation?
Sir, I'm not sure, sir.
This could be vascular tumor in the liver, sir. But that is not, you are saying it is not a liver mass. You are already saying it is a hepatic mass. So there is no need to make a mention of the point there is no bruit over the mass.
Yes, sir.
Okay. What are the other causes of bruit in the abdomen when you auscultate the abdomen? What is in your mind when you are auscultating the abdomen for bruit? What are the causes of the abdominal bruit? Just tell me.
Sir, aortic.
Yeah, good. Aortic aneurysm, renal artery stenosis, atherosclerosis of the iliac vessels. So you should have something in mind when you are doing some specific test. Every
Yes, sir.
test should not be applied to each and every complaint or the complaint in the particular quadrant of the abdomen. Otherwise, you should have an answer for that. If you would have
Yes,
said
sir.
it is a liver mass, then it could be have been okay that vascular
Yes.
liver tumors may present with a bruit or large AV malformations the liver may have.
Yes.
Okay? Okay. Proceed.
If this patient had an ascites, what is the test you'll do to find it out?
And fluid thrill.
Okay.
And shifting dullness.
Okay. Why it has not been done in your case? You didn't try to look for it?
Ma'am, I looked, but I didn't write.
You didn't write.
Yeah, your liver span is only 10 centimeter, but 4 centimeter is palpable below the margin. The rest of the liver is only 6 centimeter.
Sir, he
Oh,
said
sorry,
that
sir.
It is totally, you have put the liver span 10 centimeter. Below the
Yes, sir.
margin, it is 4 centimeter palpable. So intra that is there, the rest of the liver is only 6 centimeter.
No, sir, I mean the upper margin of the, as in the first, I could feel resonant uh, below the liver span, the lower border of the liver. After
From
that, I
where?
could start mid-clavicular veins.
sir, he has written that he is able to insinuate between the mass and the liver. So this mass, where this dullness, is something separate. Not continuous in the
Auscultation.
liver.
Any other sound you can hear there? Any other vascular sounds? Bruit is from the artery. Anything else? Can you get any sound from the veins?
Musical sound.
We
What
had
is it?
Canavi sign, Pruvillier Baumgarten sign. Have you heard or
Yeah.
you are
No,
not aware?
I'm not. I'm not.
Because it is very important, and whether you must differentiate whether you are going to hear an bruit, because commonly in this condition you are not going to get a bruit. If you think of
Yes,
other
sir.
liver pathology, you are going to get the venous sound. Whether where you are going to get, if you are going to the substernal region or you are going to get in around the umbilicus, whether there is a variation with the respiration, that depends upon that they're going to differentiate Canavi and Creville importance. But this
Yes, sir.
mistake is not an acceptable mistake, Renovat. You need
Yes,
to
sir.
be extremely careful because liver dullness, palpation of liver dullness, identify the liver dullness, all those areas postgraduate cannot make a mistake.
Yes, sir.
Clinical finding, what was your diagnosis? How you narrowed it down to hepatic flexure?
Ma'am, mainly because of the melena, ma'am, because right-sided growths, they grow to a larger size, and because of that, they outgrow their blood supply. So they ulcerate and they bleed. So that is what I thought, ma'am. That's what.
No,
That's how it got.
Ranawat, would you like to reconsider your first diagnosis, provisional diagnosis? Because melena is not a sign of colonic malignancy. No? It is a upper GI bleed. It is a
Yes,
very
sir.
strong point against this finding.
Can you get even? Can you explain then? You can get still a melena or dark color stool in a colonic malignancy.
Uh, sir, sir said before that because of the bacterial intestinal bacteria digest the hemoglobins.
So when the transit time is more, especially when it is
More.
bleeding from the colon, I mean, right
When
side,
it is
transit time,
associated with stenosis
oxidative
also.
reduction.
Right?
You can get an oxidative reduction, but by and large, when we say melena, it is on the upper bowel we are talking.
Yes, ma'am. Yes, sir.
The
What is the
PR point is
classification?
PR you have met no deposits. What deposits you looked for?
Sir, bloomer shelf, sir.
How will you
Uh,
differentiate it from growth?
so there, along with the history, sir, there
No,
are
no,
hard
you are
inconsistencies.
palpating on palpation. How will you differentiate whether it is a growth or whether it is a deposit?
Sir, they won't be mobile, sir.
Why? It's a very simple question I am asking.
Pouch of they're deposited in the pouch of Douglas, sir. So they won't be mobile as freely as the rectal growth, sir.
Rectal growth is freely mobile.
No,
The basic is you are what you are going to see the mucosa. What will we see in the rectal growth? What will be the change in the mucosa?
there
And
any
we are
ulcerations might be there, so it will be not be smooth rectal.
and you have mentioned as normal tone. What do you mean by that normal tone?
Sir, finger could be inserted without.
What is that? Is voluntary or involuntary?
Sir, involuntary, sir.
Which muscle is responsible for that?
Internal sphincter, sir.
Very good. Go ahead.
How will you manage this case?
I'm starting with blood investigations. I
No,
like.
no, why? You don't want to
Sorry?
confirm the diagnosis.
Yes,
Basic
ma'am.
information.
We look for in tumor markers, ma'am. Carcinoembryonic
Oh,
antigen.
no. Dr. Anavad, first we have to, in exam, we have to start with investigations for diagnosis of the disease, investigation for staging of the disease, and investigations for general status of the patient, or prognostic markers. And do you think tumor markers are used to make a diagnosis or to screen a malignancy, colorectal malignancy? Which
No, sir,
tumor
they're used for
marker you would
screening,
like
sir.
to? No, it's not also used for screening. Which tumor
Prognosis,
markers
sir.
are? Which tumor marker you want to do in a case of suspected colonic malignancy?
Carcinoembryonic antigen, sir.
CEA. What is the indication for CEA in a case of colonic malignancy?
Sir,
Do you want
post
to confirm the
treatment.
diagnosis by this?
No, sir.
So then why
Post
you will
treatment,
do?
sir.
Post
Post
treatment.
treatment, if post chemotherapy or surgical resection, if the values are falling down, then
Yeah. So you need a pre for the prognosis and to detect the recurrence of the disease and for the complete resection of the tumor. It is not recommended for neither for the screening, not for the diagnosis, because there's too many other benign lesions responsible for it. Increased CEA. Okay.
yes, sir.
So once the diagnosis is confirmed, then you do a pre-operative or pre-neoadjuvant chemotherapies, CA values to see the fall in this value.
Yes, sir.
Right? So start with the radiological investigation. How you will confirm your diagnosis? Radiological
Sir,
biopsy.
ultrasound.
Yes. What you will like to see? What is in your mind when you order an ultrasound in this particular patient?
So if you have the findings, you tell us. If you don't have the findings, we'll give you findings. Do you have the ultrasound report?
Sir, ma'am, ultrasound was not done.
Okay, so we'll tell you. We go by your findings that there is no evidence of secondaries in the liver, there is no free fluid, and there is a mass in the region of hepatic flexure.
Yes, ma'am.
Right, and there is
Yes, ma'am.
there is no lymphadenopathy.
Yes, ma'am.
Yeah.
Now what you will do next?
Ma'am, higher colonoscopy we can do, sir.
How will you
So,
prepare the patient for colonoscopy?
Ma'am, coloprep will give, ma'am. One day we'll keep the patient NPO. Milk for solid we will not give, sir. And coloprep will give, sir.
You will give
Two
whole
times, sir.
coloprep on what are the various ways by which you can give coloprep?
Ma'am, 1 bottle in 1 liter in in 1 liter of water, sir. Water, ma'am. At 10 p.m. and 6 p.m. After that, if they pass, they'll check for if stools have passed.
So there are 2
After
or
that,
3 ways of giving. You can give the whole dose together. You can give it in divided doses, right? One about a few hours before you do colonoscopy. How is it
okay,
done?
but
Is it done under some anesthesia or is it done? How is
if the patient
colonoscopy done?
if the patient is elderly, then we have to sedate the patient. Otherwise, not necessarily under anesthesia.
okay. So what do you want to see in colonoscopy?
So the source of the bleed, sir. So organ of origin, as in yes. The entire colon till the terminal ileum we can see, sir. So
Why do you
since I'm
want to see
suspecting,
why do you want to see the colon beyond the lesion? Once you reach up to the lesion, you take a biopsy. Why do you want to go beyond it?
have any secondary growths?
You call them secondary growth, or what do you call them?
Synchronous.
Synchronous lesion. Yes, you want to look for synchronous lesions. So for colonoscopy, you will do. You will take a biopsy. है ना?
So
You
I'm
will
the
see the lesion.
gastroenterologist. I've done colonoscopy. I find a growth in the hepatic flexure. There is no active bleeding, and I could not negotiate my scope beyond the growth.
Beyond.
How will you manage?
And if complete luminal obstruction is there, then we have to undergo surgery. We have to extend it right
This
hemicolectomy.
patient, when you examine, has got tenderness in the right iliac fossa, has got a tender palpable lump in right iliac fossa now, after 2 days. How will you interpret this clinical finding?
There's a perforation is there and it's collected to the right.
Not perforation, it's a sign of impending perforation.
Impending perforation.
Distended cecum will be tender and palpable, right? Yeah.
So
Especially
why the cecum perforates here?
Because it's highly distensible.
So it should not perforate if it is highly distensible.
It's highly, sir.
In which
because
subgroup of patients there are chances of cecal perforation in a hepatic flexure growth? Not in each and every patient. The patients who have a
I gave you the answer, you didn't pay any attention to it.
ileocecal, competent ileocecal, right? Every patient do not have that. So then the patients where the valve is not competent, they will be back pressure and the small bowel will distend. In that case, there will be no brunt on the cecum. Otherwise, cecum will bear the brunt and it will undergo perforation due to gross dilatation and decreased blood supply and ischemia. Okay.
What is this type of obstruction called as?
Closed loop.
That's what. The closed loop will go for a perforation.
Yes.
Yeah, so with these findings that you could not negotiate your scope, how will you manage this patient further?
Ma'am, we'll to undergo a CT scan to look for
When you want a CT scan, after colonoscopy has shown your growth and biopsy shows adenocarcinoma.
Biopsy has been taken.
Yes, ma'am. Biopsy has been taken. Yes,
Why
ma'am,
do
if
you need
there is
CT?
if it's an obstruction, then we should undergo colostomy, ma'am. Costomy. If it's a competent ileocecal valve, if there are signs of
No, don't assume
No,
things. No,
no.
we've
Yeah,
given you
yeah.
findings of colonoscopy that there is a growth at hepatic flexure. Scope could not be negotiated, right?
Yes, ma'am.
And then biopsy is showing you adenocarcinoma. Now, how will you manage further? You said CT scan. You tell us what will CT scan tell us beyond what colonoscopy told us.
Ma'am, any metastasis is there to distant organs?
So all extraluminal findings, right? Colonoscopy
Yes, ma'am.
told you about the luminal status. It will tell you about extent of the growth, other lymph nodes and ascites and metastasis and all that we talked about, right? So there is no regional extension, right, into the
Yes, ma'am.
retroperitoneum.
Yes, ma'am.
What will you plan further? Would you want to give this patient chemotherapy, radiotherapy, or surgery?
Ma'am, primarily curative surgery. If there are no mets, then curative surgery we can undergo, and after that, adjuvant chemotherapy can be given.
Can you tell us what surgery will you do if the growth is at the hepatic flexure?
Ma'am, right hemicolectomy.
Why?
We have to take.
What is extended right hemicolectomy?
Ma'am, in which extent in we have to take proximal 2/3 of the transverse colon is extended.
In this, you will take only 1/3.
No, ma'am, extended, ma'am.
That's not correct, no?
Yes, ma'am.
Can
Extended
you
right
give us
hemicolectomy
time
here
for
also.
it and just what is the difference in any hemicolectomy which is done for malignancy as compared to what is done in benign conditions? Is there any difference in the colectomy that you do in benign and malignant conditions?
Ma'am, since it's a malignant condition, we have
No,
to.
no, madam is saying not in this case. If you don't have a preoperative diagnosis, like there is a stenosis and you cannot go beyond the colonoscopy, you cannot take the biopsy, patient is in intestinal obstruction, right? So you'll do the exploratory laparotomy and do the hemicolectomy. What is the difference? And if you have a pre-hand diagnosis of a ileocecal tuberculosis, what will be the difference in the hemicolectomy of benign condition and hemicolectomy of malignant condition?
So, I don't know, sir.
Do with that of the mesocolon.
So you will do a total mesocolic excision. What is this Turnbull approach?
Ma'am, in terminal approach, before mobilizing, before mobilizing the tumor, we should ligate the arteries so that while
Yes.
while mobilization, the tumor cells should not disseminate.
Yeah, one is that high ligation of vessels. Then what else? And then you can ligate the lumen at both the ends also, because transluminal spread of malignancy is known. Yeah. So what chemotherapy do you give to such patients in an adjuvant setting?
Ma'am, false fox regimen, ma'am, folinic acid, 5-fluorouracil and oxaliplatin. This should happen in stage 1, 2, and 3, ma'am. For advanced cancers, we have to give
In stage 1, do you
targeted
give
therapy.
chemotherapy is required in stage 1 patients?
What are the margins you look into it after doing a hemicolectomy?
Ma'am, clearance of 5 centimeters should be there, and along with minimum of 12 lymph nodes should be examined.
What is CRM?
Yeah, no, ma'am, I don't know.
Heard of circumferential radial margin?
No, ma'am.
Okay, thank you so much. I think we can,
Thank you.
Dr.
Yeah,
Kanagwal has
move
been,
to
we can move to the
next
next
case.
case. So, Rishabh,
Thank you, ma'am.
learning lessons for you.
Yes, ma'am.
What learning lessons? You need to examine the patient thoroughly.
Yes,
You
ma'am.
must have a minimum data set for yourself so that you don't miss out on the findings that you write. You must
Yes,
phrase
ma'am.
your sentences clearly. And anything and everything that you write, you should be able to
Justify.
demonstrate it to the examiner. Anything that you cannot demonstrate to the examiner or to yourself should not be written in the, no findings should be quoted, right?
Yes, ma'am. Yes, ma'am.
Yeah.
Thank you.
All the best.
Thank you.
Thank you,
Thank you.
Rishabh.
Thank
Thank
you.
you,
Thank you,
faculty.
everyone.
We move on to
Good,
the
you
next.
presented. Very nice.
Thank you, Ratna ma'am. And Muthubadivu, are you with us?
Yes, sir.
Okay, ma'am. Please switch on your video and share your PowerPoint. Introduce yourself.
Yes.
You are unit chief, you're head of the department, and start presentation.
Rishabh
Rishabh, I
has
think
to
you have to
unshare.
unshare your screen, Kana. Thank you. You make it full screen, ma?
Yes, sir.
Good luck to you, ma. All the best.
Thank you, sir. Good evening, all faculties. I am Dr. Muthuvadivu, final year postgraduate from Coimbatore Medical College. Today, I am going to present a case of neck swelling under the guidance of my professor and HOD, Dr. T. Srinivasan, and my unit chief, Dr. Narayanamurthy. A 45 years lady who is a housewife coming from Goitre came with the chief complaints of swelling in front of the neck for history of presenting illness. The patient was apparently normal 1 year back. After that, she noticed a small swelling in front of the neck while dressing, which is insidious in onset, gradually increasing in size and attained the present size. No history of rapid increase in size, not associated with pain and fever. No history of dyspnea, no history of dysphagia, no history of change of voice, no history suggestive of Horner syndrome. No history of excess sweating, no history of loss of weight in spite of increased appetite, no history of heat intolerance, no history of diarrhea, no history of sleepless nights, no history of muscle weakness, no history of tremors, palpitations, and no history of dyspnea on exertion. No history of weight gain, constipation, no history of cold intolerance, no history of easy fatigability, no history of loss of hair, no history of lethargy. No history of syncope, no history of loss of appetite and weight loss, no history of bone swelling and bone pain, no history of cough with hemoptysis. Past history, no history of similar complaints in the past. She is a known case of hypertension on regular medication since 5 years. Not a known case of diabetes mellitus, coronary artery disease, COPD, tuberculosis, epilepsy, or jaundice. No history of any childhood irradiations. No history of myomectomy for fibroid uterus 15 years back. Her drug history, she takes amlodipine tablet twice a day since 5 years. Personal history, patient consumes mixed diet, iodized salt, no history suggestive of excessive consumption of vegetables of Brassica family, no history of insomnia, bowel and bladder habits are normal, her appetite is normal. Family history, no history of similar complaints in the family members and no history of cancers among the family members. Menstrual history, attained menarche at 15 years of age, normal flow, regular cycle, 3 about 30 days regular cycle. She attained menopause 5 years back at the age of 40. Obstetric history, she had 2 children, para 2, like 2, both full-term normal vaginal delivery. Summary of my history. A 44 years lady presenting with painless swelling in front of the neck for the past 1 year, which is insidious in onset, gradually progressive in nature, with no pressure symptoms, probably a thyroid swelling.
So, Dr. One thing, you've completed the history, and from your history, I have not been able to make out what was the size, other than the image that you showed, and what was the size of the swelling to begin with, and how big is it now? You said it was small to begin with and has increased to attain a current size. I don't know how small it was
The
then.
current size is 8. The current size is 8 cross 5 centimeter.
So you should
Change
be
your
able
slide to
to
the first
see.
slide, ma. Change your slide.
Yes.
Next.
So you should be able to say how big it was how big or how small it was when it started, as gestured by the patient, and how big it is now. Right? And then I don't know if this is the only swelling in the neck or if there are more swellings also. Did we talk about that?
Yes,
You've given a big laundry list of so many no history of this and that, but we don't know if this is the only swelling or is there any other swelling also. Have you mentioned it anywhere that this is a single swelling in the neck? That we should be able to, when you talk about swelling in front of the neck, it could be a midline swelling or it could be a lateral swelling. So as much we should be able to say, even in history, that she complains of swelling in the midline of the neck or on one side of the neck or where. So these are gross things which should be present in your history, right?
Okay.
And
do
you
US
said,
check,
Dr. Manju, there is gradually increasing in size, and then you write no history of rapid increase in size. Once you already mentioned it is gradually increasing in size, so there is no need to mention again. There is no history of rapid increase in size. What is in your mind when you have written this point?
It is not a malignant swelling.
Not a
think
malignant
again.
swelling.
For a
Or any
swelling
other
which is gradually increasing in size, and now
Yeah.
she says it was gradually increasing in size say, for last 6 months. Now for last 2 days, it has suddenly increased in size. What could be the possible cause?
What
Is it a
could-
possibility? Is it not a possibility?
It is a
Justify what you've written, no?
Okay.
Is it a possibility? Is it not a possibility?
Yes, ma'am. It may be.
What can happen in a swelling that it can suddenly increase in
Sudden
size?
hemorrhage into the
Hemorrhage in a cyst if it's a cystic swelling, right?
Yes.
Yeah.
So there's a
Has it
difference
ever
between
decreased in
rapid increase
size?
and sudden increase. Okay, you must appreciate that.
Yes.
There's a difference. Yeah.
What do you mean by insidious onset?
Yes, answer.
Yes.
You've been asked a question. What do you mean by insidious
Sorry,
onset?
ma'am. I didn't hear the question, ma'am.
Ma'am is saying, what do you mean by insidious onset?
Insidious in onset.
It is not suddenly appear. Gradually, she noticed it.
Then you need not write this thing. You said she's noticed a small swelling.
Okay, sir.
Just end with it. She noticed a small swelling, and you can give a reference of a size, sometimes peanut size or approximately 2 centimeters. The patient is educated in the femurs, it roughly 2 centimeters. And first she noticed.
Okay, sir.
Did the swelling ever decrease in size?
What, ma'am?
Did the swelling ever decrease in size?
No, ma'am. The swelling.
What is the significance?
What?
Supposing she said that there was this swelling, it increases in size and then it also decreases in size sometimes. Are there any such swellings in the neck that can increase and decrease in size both?
Cystic swelling.
You only said that you are thinking in terms of thyroid. Can there be any thyroid swelling also that can decrease in size after it is formed once? So you have to keep your mind open. Are there any inflammatory swellings of thyroid also?
Yes, ma'am.
So they can decrease in
Hashimoto-thyroiditis.
size?
Yes.
So why did you take this history of pain and fever?
To rule out any inflammation
Where?
in thyroid or in the swelling.
Inflammation. You mean inflammation?
Infections.
Infection or inflammation? What is the difference? What do you mean by inflammation?
Thyroid?
Is it the infection is common in thyroid?
Inflammation.
Inflammation is the response of the tissue. It is not that something is affecting that. It is not that external. It is a response.
Okay.
So infection is the right word, but is it infection is common in thyroid? Thyroid infection is not common because it has a rich blood supply, rich lymphatic, thick capsule, and the chemicals are there. So, but still you can get thyroid abscess or you can get in a pediatric age group. That's one solely which can increase and decrease in size. And your first sentence starts with apparently normal. By the history says patient has a 5 years hypertension, patient has undergone a myomectomy, but according to you, all are normal, no?
According about the swelling of neck, actually.
History you are presenting. We do not know whether you are starting with the history of neck or anything else. But the first sentence is, according to you, is normal before 1 year, and all this problem started within the 1 year. Please tend to avoid that sentence. You are not going to say there is 1 year, and in the past history, you will say he is a diabetic for 10 years, then problem for that will be there. So you are going to talk about the swelling started with the 1 year back. And and very
Dr. Mathu?
in the right side, which you have to, as madam has very rightly insisted, and where it has started, is it the single swelling, whether it is increasing and decreasing in size, all that has to be included.
Why you are thinking in the line of a thyroid swelling from the history?
Yes, sir.
Why? Why it cannot be other swelling? There are no signs of, I think, hypothyroidism or hyperthyroidism. Are there any signs?
Sorry, sir, I didn't get you.
In this patient, is there any sign of hyperthyroidism or hypothyroidism?
No, sir.
So your all history was negative. So why you are thinking only in line of thyroid swelling, which is the most common neck swelling?
Please just give a reason for why you've spoken. No, don't keep quiet. It's always a good idea to respond one to one.
Why it is not a lymph node?
Yes.
Hmm?
It is in the region of thyroid and it moves with deglutation.
No, from the history, how you can see, we have not done these tests, no?
Okay,
based on the history, why it is not simply a lymph node, which is gradually increasing in size?
Can be said.
What is being made region of thyroid? You said there is a region of thyroid, no? What is that? What do you?
Yes, sir.
What are the boundaries of thyroid?
Superiorly from the thyroid cartilage.
What is the size of thyroid cartilage? Normal size of thyroid cartilage?
Sorry.
No, it's more than 2.5 centimeters. It's a large one. So when if you say we do not know whether it's an upper border, lower border, middle oblique line. So
upper border from thyroid cartilage and lower.
No, not upper border. No, it doesn't go beyond the oblique line on the thyroid cartilage.
Why it will not go beyond the oblique line?
Because of cancer.
What is fixed there? Thyroid is enclosed in?
Pretracheal fascia. Suspensory ligament of Berry. In a capsule.
Any muscles there in the thyroid cartilage?
Inferior constrictor muscle.
Inferior constrictor of the pharynx.
It attached.
What
Required
are these
coordination.
muscles? No, strap muscles of the
Strap
neck.
muscles. Yes, ma'am.
What? Name them. See, you only have distracted the examiners.
Sternohyoid, sternothyroid, thyrohyoid, and
yeah.
So that is when you say region of thyroid, you must know what is the boundary, and then you are right. I mean, otherwise, without understanding, don't use those words. No, it is better to use the word region thyroid, but it is always go and read the basic anatomy of that and what is the upper border, what is lower border, because this is very basic of anatomy. You must know.
Yes,
Next
Proceed
slide.
to the next slide.
The change of voice. You said no change. What change you expected?
You are written as no change of voice. No, what Madam is asking, what are the changes in the voice you can expect?
Hoarseness of voice.
What do you mean by that? Hoarseness of voice.
Palsy of recurrent laryngeal nerve.
I'm not asking the etiology. No? What will be the voice?
Hoarseness.
What do you mean by how do you ask that question to the patient? How do you understand it is a hoarseness of voice?
Any change of normal voice
Any
of the patient and pitch.
Any change is a normal voice, hoarseness of voice. Then what do you get? The huskiness of voice?
In pitch of voice is change.
If hoarseness is also pitch, then why it is called as huskiness for external laryngeal nerve?
Yes, ma'am. Huskiness is.
So be very clear about the types of changes in voice that you need to ask about. Right? Well, what one you've described as hoarse voice, second pitch and tone. Then you need to ask about voice fatigue also. Right?
Yes.
What did you ask when you've written no history of dyspnea?
Any difficulty in breathing?
What kind of difficulty were you expecting? I think somewhere you've written dyspnea on exertion also.
Yes.
Why would a patient of so-called thyroid disease have dyspnea?
Because of tracheal compression, bilateral recurrent laryngeal nerve palsy.
All are very, very rare things. Huh?
How much tracheal compression do you think you need to have for dyspnea to happen? Yes, are we there?
Long-term compression of.
Long-term, already I'm asking about the lumen of trachea. No, how much must it be narrowed? More than 75%. No, usually it gets reduced to a lumen of less than 1 centimeter for it to cause dyspnea.
You said it's exertional dyspnea. No, in what condition? Somebody with a thyroid swelling complains of dyspnea on exertional. What do you suspect? Somebody with the thyroid complain of the hoarseness of voice. What is the common thing you suspect?
Pressure symptoms.
No, they are very rare. Understand the common things are common. What is the very common is, can you get a hypothyroid produce a hoarseness of voice?
Sir?
Hypothyroid condition produce a hoarseness of voice.
So, large goiter, if it compresses, it can cause.
I'm not asking that. I said, can just the patient has a hypothyroid myxedema? What are the features of myxedema?
She don't have any features of myxedema.
What are the features?
Lethargy, fatigue.
And what will be her voice?
There is a definite change in the voice, no?
Yes.
So don't get nervous. Take a deep breath. You've read, so think and answer.
You might have seen a lot of patients with severe hypothyroidism.
Yes.
So they will have a puffy face, and what will be their voice?
Hoarseness.
Hoarseness of voice. Due to? What is the cause for that? Is it laryngeal edema?
Recurrent laryngeal nerve pains.
No, in mixed edema.
In mixed edema, due to the compression.
This infiltration of the nerve, compression, all it's not very common thing to you get. What you're getting commonly, you must rule out hypothyroidism. Similarly, when the patient comes with a dyspnea, you need to rule out the secondary hyperthyroidism. That is a common because a lady comes with a long-standing thyroid. So always think of a common things first. Rule out. Just because you have a thyroid, don't always think it is going to compress. And again, please understand, it is not the malignant infiltration is the common cause for even recurrent laryngeal nerve. It is only the compression with the benign only. It's the most common.
Yes.
Talking about narrowing of the trachea. Madam was telling about almost 2/3 it will be narrowed. No. What is this narrowing of tracheal appearance called as? What is the type of trachea called as?
Scabbard trachea.
What do you mean by scabbard?
It's the trachea, the continuous compression of trachea causes tracheomalacia, softening of trachea. Then it causes.
Now, what does the scabbard mean?
Tracheomalacia is different from scabbard.
Scabbard is nothing but the sheath of the sword. Okay.
Okay.
It will have a narrowing in such a way, very small space would be there, right? That's why it's called as a scabbard trachea.
It is not anterior to posterior. It is a medial to lateral. It's a scabbard. This comes in the compression from there. Tracheomalacia is really different. What is the shape of the trachea? Normal shape of the trachea? Normally, what it will be shaped like what? It is all is a tube or anything? Circular tube.
Yes. Tracheal ring.
Only the tracheal rings will be only in the anterior. The posteriorly it will be the muscles, the flat. So it's a D shape, not the complete circular shape.
Okay.
Yeah. Why did you ask about Horner syndrome?
Whether there is any compression of sympathetic trunk.
So in which cases do you expect this to happen?
Ma'am?
In which cases of neck swelling do you expect a Horner syndrome to happen?
Tumor. Head and neck
So
cancers.
either malignancies of thyroid or metastatic lymph nodes, right? Move to the next slide. Right. So what did you want to rule out by this whole list? You could have just written that there is no history suggestive of, and you could have kept this list in your mind, hypo or hyperthyroidism.
Hyperthyroidism.
Yeah. So how did you take history for tremors? You've written no history of tremors. What did you ask the patient?
Whether she had any trembling during working or.
You mean to say she should have had gross tremors, coarse tremors?
What type of tremors she will have?
Fine
what type of tremor they will have?
Fine tremors.
Why it is fine tremor? What do you mean by fine tremor? What is tremor?
Trembling of hands and.
That is a handshake. Trembling of the hand is not tremor. There is a definition for tremor. No? It's a voluntary or involuntary. That is all. You can also shake hands voluntary. That is also tremor.
Involuntary movement.
Involuntary. Rhythmic.
Involuntary movement.
So when you say it is a fine tremor, a tremor is a fine tremor. Is it pathological or physiological? Fine tremor is a pathological one or physiological one?
Pathological ones.
You go to the examination, what tremor you get?
Fine tremors, sir.
So that is pathological. Fine tremor is physiological. In a thyroid, you are getting increased sympathetic stimulation that is
Yes,
going exaggerated physiological response,
okay.
and which the history wise you can't elicit. Patient will not be able to give a history that I have a tremor. If he says a tremor, that is not a fine tremor.
Okay, sir.
So indirectly, what history will you elicit from the patient to see if she could be having fine tremors or not? There would be a change in her handwriting. She's likely to be dropping objects more frequently,
While working.
right? Yeah.
Yes, sir.
Move to the next slide.
But
What kind of history of loss of hair did you ask for?
But it is very difficult to get that history from a lady saying that I do not have a loss of hair.
Yeah. So what? No history of loss of hair. So what exactly did you ask for? From where is she losing hair?
Over the forearm and leg.
No. One is the scalp, of course, in hypothyroidism,
Yes.
and there is a gross loss over the outer end of the eyebrows. Okay.
Yes.
Yeah.
As a postgraduate, do not write no diarrhea, no constipation. So you are asking the history and then you are committing. If you say bowel habits is normal, that
Okay,
covers everything, and no loss of weight, no weight gain. So both negative side don't write in the case sheet. We would
Okay, sir.
like to have what is you are going to see in overall observation. It's not a serial things you are writing hypothyroid features first, hyperthyroid features first. After taking the history, eliciting the history, you are going to present. So comprise your findings and write. No
Okay, sir.
history of fatigability, no history of lethargy. What is the difference in this both?
Easily, if while doing work, easily getting tired is fatigue, and she don't like to do any work. No, not even is
So
lethargy.
they are all features of thyroid.
Hypothyroidism.
So what do you get in anemia?
Anemia also you will get fatigabilities.
So why you are particularly asking this question? Fatigability is a feature of many other things. It's not going to give you a clue that just because he is saying fatigue, you are not going to say she is a hyperthyroid.
Yes.
No lethargy.
So it will be good if you would write there is no history suggestive of hyper or hypothyroidism. And you can keep this long list in your mind so that if you're asked this question, you can give an answer.
Okay.
So move to the next slide. So no history of loss of appetite and weight loss. Why did you ask this history? No, is this to rule out hyper and hypothyroidism? Is it to rule out malignancy? Is it to rule out tuberculosis? What?
To rule out malignancy.
In earlier you had written in no history of
Loss of appetite.
This you're writing now. No? There was one sentence earlier also. With
Yes.
increase of
Dr.
appetite
Muthuvedu,
also there is
Dr.
no
Muthuvedu,
loss of
sorry.
weight.
Yes.
Dr.
No.
Muthuvedu,
Yes, sir.
I'd just like to come in. Just look, what is your patient? He's got a thyroid swelling with no other symptoms,
Yes, sir.
right?
Yes, sir.
So if you have to even rule out hyper or hypo and malignancy or another, club them together. You can't keep on repeating loss of appetite and weight loss. You've said it before also. You're saying it again also. You said that time I was talking about hyperthyroidism. Now I'm talking about malignancy.
Yes.
You can't have different like this, no?
Yes, sir.
So proceed to the next slide.
Your hemoptysis in thyroid, how do you expect?
Due to lung metastasis, sir.
Is it common? What is more common?
Bone metastasis, skeletal metastasis.
Thyroid with the hemoptysis. Somebody is cough, blood is coming. What do you suspect? So, in a malignancy, it is not the secondary which is going out. It is very close to trachea. It is infiltrating into the trachea. It's a direct infiltration in the trachea. That is how we present with that.
Okay.
In your history taking, you should not have a generalized opinion, putting the generalized words. For each case, there are specific way you are going to ask, specific way it is going to present. Not routinely saying bone swelling, bone pain. Yes, you get the bone swelling. It is very, very rare to get a bone swelling for this case. The history wise, you said no other swelling. Go ahead.
What is this? No similar complaints in the past?
No any other swelling before.
No, if there is a history of past, similar complaint, will it come in the past history or present history? That will become, if you have that history, you should trace back. So what is the origin? Because in the present history, you are going to present the biodata of the swelling, biodata of the thing, entire thing, from the birth. So if that could have been the reason of the etiology, that should be brought in the present history. So don't use this, and never, any time in the history, use the word similar. You cannot have a similar.
Okay, sir.
Whatever the things you expected, if it is a problem with the thyroid, as you are mentioning about your family history.
Of irradiation. What irradiation you wanted to know about?
Radiation to head and neck for any tumors or normal X-ray radiations.
X-ray radiation.
Radiation to the neck, head and neck for
What do you mean
tumors.
X-ray radiation? So that will cause thyroid cancer.
No, sir. Tumor, any head and neck tumors in the past during children period.
What tumor? Children, head and neck. What's the common cause? Common disease, can you think of that? What will be the they would have undergone in the second decade? What is the tumor which have the bimodal age group presentation?
Anything to do with the nodal disease?
Primary lesion of the node. Okay, good. It's a lymphoma.
Yes, lymphomas.
So drug history, you've written amlodipine. Are you aware of any goitrogenic drugs also? So you should know about some cardiac drugs like amiodarone and then antitubercular drugs. You must know about what are goitrogenic drugs and what are goitrogenic food items. What are they?
Food items is a vegetables of Brassica family.
Like?
Brassica from what vegetable?
Cabbage, cauliflower.
What it contains? Why it produces goitrogen? And again, you are not going to take cabbage in a salad form. And you are going to take cabbage in a cooked form. Whenever you cook or fry it, and the thiocyanate will be lost. You will not getting that. So Indian setup and our South Indian setup, what you are taking cabbage is in a fried form or a cooked form. When you boil it, the thiocyanate will lost it.
That's true.
Only when you are taking it as in a salad, as a raw vegetable, and that has a cumulative effect. So our setup, it is very, very rare. Let's say talking about cabbage and flavonoid, both. We don't take the soya beans also, raw soya beans. So that goitrogen is very rare in our setup.
So do you think she has got an endemic goiter, or do you think she's got a sporadic goiter?
Not an endemic goiter.
Why do you say so? When do you say that a goiter is endemic? Any definition of endemic goiter?
An area, no any history of similar complaints in the family members or in the area.
Yeah. Now that we are asking you this question, you should know by definition how many people in an area must be involved with goiter for you to call it endemic goiter.
So one person in the family will not cause endemic goiter.
So if there is 10% incidence of goiter in an area, then only it is considered as an endemic zone. What is the cause of endemic goiter?
Iodine deficiency.
What are other iodine deficiency disorders that you know of? Did this patient have any features of iodine deficiency?
Why do you get iodine deficiency? In which part it is common? Iodine deficiency is, we get a lot of cases around the coastal belt also. Coastal belt has a lot of iodine. What is the reason when you get in more in a coastal belt? When you take, especially when you take fish, has a lot of the small fish, though they are rich in iodine, they will prevent the absorption of the calcium, will competitively inhibit the absorption of the iodine. So the most of the area, the coastal belt people are getting, not because of lack of iodine. There is iodine is there, but they are not absorbed when you take the food. Where it is absorbed, you know the mechanism of iodine synthesis completely, what steps of iodine synthesis, physiology. Oh, if you're not read, please read that. But that's also very important. Physiology of iodine, where it is absorbed, what are the steps involved, what are the enzymes involved in that, all that you should read.
Yes.
So other than symptoms, how can you make out? Is there any biochemical test that can tell you about iodine deficiency? So you need to look for urinary iodine levels, right? Okay. Let's proceed.
Here again, you are talking about hepatitis normal, insomnia.
Yes. Well, correct it, sir.
Yeah, in the similar complaints in the family members, you can write no other family member has suffered from thyroid disorder or head and neck malignancies like that, right? Yeah. Proceed
At the
to
end
the
of the
next.
present history, you are having a probable thing. What system you are dealing with, what disease you are dealing with, you come to conclusion. And that you should put. So no family member is having a liver disorder, stomach disorder, or thyroid disorder. Don't put the word similar.
Yes, sir.
What are the syndromes
proceed to the next
associated
slide.
with thyroid?
Ma'am?
Any syndrome associated with thyroid
Family history.
in family history?
Men syndrome, ma'am.
Men syndrome, good, right?
Men 2A and men 2B.
Then any other syndromes associated with
Cowden syndrome.
Cowden
syndrome.
Okay.
Yeah, so all these normal age at menarche, normal pregnancy and all this tells you that she probably did not suffer from iodine deficiency from childhood till now. You know the normal iodine intake, how much should it be?
0.2.
So for an adult, it should be somewhere between. See, these are important things from national and social point of view, also besides surgical, no? So you have to know them. 100 to 200. And if a pregnant lady needs to be replenished with iodine immediately, what are the various ways by which you can do it? How can you replenish her iodine stores? Otherwise, she'll produce a cretin, no? You need to know that the injectable forms are also available, right? As iodized oils, which can be given intramuscularly, and their duration of action is for 3 years. So they are useful. Proceed to the next slide. Yeah, so from history, you're thinking in terms of a thyroid swelling, right? Let's come to examination.
General examination. The patient is conscious, oriented, comfortable, and cooperative, moderately built and nourished, no pallor, not icteric, no cyanosis, no facial puffiness, and facial expressions are normal, no clubbing, no tremors, no pedal edema, no pretibial myxedema, no dryness of skin or excessive sweating, no eye signs, no peripheral significant lymphadenopathy or no proximal myopathy. Her vitals are pulse is 71 per minute, regular in rhythm, normal in volume, respiratory rate 17 per minute, BP is 130/80 mmHg, measured in left upper limb in sitting posture. The temperature is, she is afebrile. Local examination. After getting informed.
Wait for a second. Let's go back to general physical examination. So you said no tremors. How did you look for them?
By outstretching the hands with the outstretching of fingers.
That's all. How the test is described?
Whether she had any trembling during the outstretching of hand and fingers. And the tongue also.
No.
Give us a classical textbook description of this clinical sign, how to elicit it. You've initiated it by what you've said. You switched the fan off. Can you do something to exaggerate the movements so that you can see them clearly?
Any paper test, you know?
Cut it and put it over the fingers and try to see. You switch off the fan.
Keeping the papers inside the finger.
Not inside, that's for lumbricals, no?
Over.
Yeah, over the dorsum of the hand, and look for the movement of paper because that will show you the exaggerated movements of fingers, right? You said there is no pretibial myxedema. What does pretibial myxedema look like?
Shiny, patchy like appearance over the shin of the.
What is it? An elevated patch? Is it a depressed patch? Flat, red, white?
Elevated red, shiny red patch.
Is it suggestive of myxedema? Is it hypo or hyperthyroidism?
It is hyperthyroidism. It is due to the accumulation of glycosaminoglycans.
Yes, so here in general physical examination, we also expected you to write about loss of hair on the chin or on the eyebrows also. Dryness you have already mentioned. Yeah.
How do you check for the clubbing in thyroid? Where do you get the clubbing?
In thyroid acropathy, sir. In hyperthyroidism.
Where do you look for it? How it differs from clubbing, acropathy?
Sir?
How it differs from normal clubbing?
The
Is a fluctuant swelling you get there?
no, sir.
So what is due to acropache is due to what? Why you are saying it is an edema in preterm mixed edema? What edema comes from where?
Accumulation of.
That is accumulation of glycosamines.
Yes, sir.
That we don't call it as an edema accumulation. Something is accumulating, it is not edema.
Mucopolysaccharides.
So they are hygroscopic.
Okay, sir.
Gloves there and they produce.
Proceed to the next slide, please. Please present.
Local examination. After getting informed consent, patient is examined in sitting position in a well-lit room. Swelling in the anterior inspection. Swelling in the anterior aspect of neck in the region of thyroid of size 8 × 5 cm. Lower border is seen. Swelling moves with deglutify in shape. The surface appears to be smooth. Margin is well defined. The skin over the swelling is normal. No scar, no sinus, or no visible pulsations. Trachea appears to be in midline. Extent of swelling. The superior border is 1 cm from the upper border of thyroid cartilage and inferior border 1 cm from suprasternal notch. Right lateral border, anterior border of right sternocleidomastoid muscle and left lateral border 1 cm from the anterior border of left sternocleidomastoid muscle. During palpation, the patient is examined in sitting position and the examiner standing behind the patient by classical method. No local rise of temperature, non-tender. All inspected findings of size, shape are confirmed by palpation. The swelling of 8 × 5 cm in the anterior aspect of neck in the region of thyroid, which is butterfly in shape. The surface is nodular, which is firm in consistency. The plane of swelling is deep to strap muscles. Carotid pulsations equally felt on both sides. No palpable thrill. Trachea is in midline. Percussion. Percussion over the manubrium sterni is resonant. Auscultation. No breaths heard. Breaths once heard in the midline, confirming the tracheal position. Examination of lymph nodes. No any palpable lymph nodes in the neck. Other system examination. Cardiovascular system. S1, S2 heard. No any murmurs heard. Respiratory system. Normal vesicular breathing sounds heard. No any added sounds. CNS. No focal neurological deficits. Spine and cranium normal. Perabdomen or soft and bowel sounds present. Musculoskeletal system, no proximal myopathy, no bony lesions, no bone pain. Examination of scalp is normal. Summary, a 45 years female with complaints of swelling in anterior aspect of neck for the past 1 year with no history of pressure symptoms, hypothyroidism, malignancy and metastasis. On examination, 8 × 5 cm firm nodular swelling is present in the anterior aspect of neck in the region of thyroid.
When did you saw the butterfly last? Have you seen the butterfly in the recent past?
Yes, sir.
When?
Here in my home, I am seeing daily, sir.
So this looks like a butterfly.
Yes, sir. During extension, it looks like.
It's a bilateral swelling.
Yes, sir.
There is a head for the head of the butterfly is there or not?
So what he's trying to take the hint, no? What sir is trying to tell you is don't call them butterflies or caterpillars, no. So just say that the thyroid is enlarged and say right lobe is enlarged more than the left.
More than
And
the
you can visualize the isthmus also. Don't call it a butterfly or anything like that.
Okay.
And why you have done the percussion on the sternum?
To look for any ectopic thyroid tissues.
Ectopic thyroid tissues. In how many individuals you get ectopic thyroid tissue? Usually this test is done to see the extent.
There is no retrosternal. We can see for retrosternal extension, sir, but lower border of thyroid swelling is seen in this patient.
So why you are going for it? There is no sign of thyrotoxicosis or hyperthyroidism.
Any better tests for retrosternal goiter, Dr. Muthu?
Sir?
Any better tests for retrosternal thyroid or retrosternal extension?
X-ray.
No, clinical
test. Clinical.
Test.
Tell us the findings on inspection.
You've got the pembertons.
And the test.
Right. And if you do a Volsovers, can pop out.
You have said three times thyroid region. The swelling is the thyroid region. And again, you are talking about extent. When you are very firmly saying thyroid region, please don't write the extent again. Upper border of the thyroid, lower line. And you have said the swelling is up to the anterior border of the sternocleidomastoid, no?
Yes, sir.
And how do you find out the swelling is deep to the sternocleidomastoid in your plane of the swelling? Normally, the swelling is not going. It is going only up to the tip of the main border of the sternocleidomastoid. But you are saying,
can the thyroid swelling go above the sternocleidomastoid? Can it go above the sternocleidomastoid? The thyroid swelling?
At any time.
If yes, why? If not, why?
Muscle.
Look, it cannot. Because the deep investing near the deep cervical fascia encloses the sternocleidomastoid and then goes over the thyroid, right? So the thyroid cannot go above. It cannot pierce the cervical fascia and move out, right? So it has to always lie below that, right?
It is better to say the plane of the swelling is within the thyroid fascia, pretracheal fascia. It is enclosed within the fascia. And how do you know it is? You said it is not moving with the deglutition, which is moving with the deglutition. How?
Because the inferior constrictor muscle attached to the thyroid and cricoid cartilage, and the ligament of Berry is attached posteriorly to the cricoid cartilage. So during deglutition, the cricoid moves up, so the thyroid gland is also moved up.
You have said only the ligament of Berry, then why it moves? We are coming from reverse to there, but okay, fine. How many ligaments of Berry is there?
One ligament, it attaching over the both sides.
One attaching both the sides.
Like a suspension.
No. How do you say one attaching on both sides?
Condensation of pretracheal.
Is it one or two Berry's ligament?
One on either side, or only one which attaches both the lobes? Yes, doctor? Are you there?
Yes, ma'am.
Yeah.
You assisted thyroid surgery?
Yes, sir.
Okay.
Yes, so where were we? Let's go back to your previous slides now, with examination slides again.
Yes, ma'am.
You said both the carotids were palpable. Make it a point to write common carotid,
Yes,
right? Because there is external carotid, internal carotid, and common carotid, no?
Yes.
Yeah. So other than the fact that they were equal in volume, what else did you look for?
In carotid pulsation, ma'am.
Yeah.
You can go to that slide.
You've written carotid pulsations equally felt on both the sides. So I assume you are palpating common carotid artery. So common carotid artery pulsations were equally felt on both the sides. What else did you look for? Were they present at a normal position? Were they displaced?
To look for normal.
No. Were the common carotid vessels present at the normal anatomical position or were they displaced?
No, it is present in the normal anatomical position, ma'am. In the upper
What is
anterior to
What
the
happens in benign enlargement of thyroid?
it displays to the posterior surface.
So what is
Yeah.
very sign?
Yes, sir. It is very sign. No, it is not. It is very sign. If the carotid pulse is absent on one side, then it is very sign, sir.
What do you mean by carotid is absent? Is it the blood
tumor
is
invading the tumor invading the vessel or compressing the vessel? So there is no pulsation over the side of that carotid artery. It is a very sign.
If there is a blood flow, is the blood is flowing or blood is stopped there?
Blood is flowing.
So it encases basically the common carotid.
You've written there is no palpable thrill. Where did you palpate for the thrill?
Over the upper pole of thyroid.
Why over the upper pole?
It is.
What artery is there?
Superior thyroid artery.
What artery is there in the inferior pole? What is there in the inferior pole? What is there in the inferior pole?
Inferior thyroid arteries.
For sure. It goes from
Inferior
vertically
thyroid is
upwards.
not on the inferior pole.
Ma'am?
Why did you palpate for thrill on the superior pole? Because superior thyroid artery is more superficial as compared to inferior thyroid artery, right?
What are the methods by which you check for the tracheal position?
Ma'am?
Anandi, your voice is little low.
Position, what are the methods?
I have to take a coffee and ask.
Ma'am, your voice is coming is a bit low. Yeah.
What are the methods by which you check for the tracheal position?
By inspection, by palpation, what are the methods?
While examining the thyroid, Koch's test.
On inspection, what is the finding? Palpation, what is the finding? What other ways of examining thyroid is in the middle?
On inspection, the tracheal deviation can be visible, sir, if it is deviated.
What is trail sign? Tell us that.
Trail sign. What will happen to the sternomastoid?
It is laterally displaced.
No.
And
it is more prominent, no?
Yes, it is more prominent.
The side where
on the deviated side or the non-deviated side?
On the deviated side.
How do you palpate for trachea being in the midline?
How many fingers do you use? How do you palpate?
3 fingers.
Where do you place them and what do you do?
By compressing the thyroid, by moving the.
You have to read your clinical methods, no?
How many tracheal rings will be there in the neck? We lost her.
You can't see her.
Yeah. Must
She
be
has some internet issue, I think.
Yeah.
Let us give her some.
You are in the theater or what's it? Can I will say?
No, sir. Just finish work, sir.
We missed you today in Kanyakumari.
Sir, unfortunate, sir, because every arrangements from the beginning we were planning, then I could not make it. I will try calling us.
Yeah, somebody can call me.
Yes, joining. So she's joining.
Yes, sir. Yes, sir. No, during the early part also, she had some issues. Then she.
She's from Coimbatore Government Medical College, or?
Sorry, sir. She is from Coimbatore Medical College, sir. Yes, sir.
You can unmute yourself. What do you?
She is having some connectivity issues, which she is trying to sort out. But in the meantime, probably if she's not joining, maybe I can ask the examiners to sum up and we'll call a close. We'll give another 2-3 minutes time.
This has joined, but
Muthu, I think you should unmute yourself, ma. Don't worry if you are not able to show your slides. Shanti Vadani, would you like to continue the discussion? You can switch on the video.
Sir,
You can
sir,
switch
I
on
am
the
on.
video.
Uh,
Okay, good. Shantivadni, you are from which college?
I am from Usmania Medical College, Hyderabad, sir.
Okay, then I think
I am a
maybe faculty
consultant.
can. Oh,
I
you
am
are
a
already
consultant.
I'm sorry. I'm sorry. I thought you were a student.
No, no. But nice discussion today. It's happening. The thyroid case is really doing very well. That girl is doing very well.
Ma'am, we have more than 24 thyroid cases discussed and is available in the YouTube. Which whenever you find time, you could
Yes,
see
sir.
the YouTube channel and try
Yes,
looking
sir.
into it.
Yes, sir. Very nice initiative, sir, from your side. Well
Uh,
appreciated all over India with the PGs.
Thank you, ma'am. Wish you could join us
Yes,
now and
sir.
then whenever time permits. And also you
Definitely.
can permit few PGs to present a case here.
Yes, sir. Yes, sir. I'll try.
Right.
Right, sir. Okay.
Ma'am, Ratna ma'am and Anandi ma'am, Hemant sir, maybe you can give a closing comments for this case and we'll call a close, ma'am. I think we have given enough time for them.
Already 10:15, so you can.
Yes, sir. So
So I
maybe I
think
will ask you.
the girl should be communicated that she's intelligent, but she should not rely on only recall to present cases. They'll
Correct.
have to read their clinical methods even after they've taken history and examination. They must read from the book and get back to the case again and then read
Correct.
a little bit of theory. It's a great initiative they are taking to present that is very creditable, but then
Yes,
that
ma'am.
cannot compensate for this little bit of reading and practice that they need to do.
Correct. Point is well taken, ma'am. Anandi ma'am.
And so maybe both the
I think,
students are just
yeah,
fresh JR3s, I think.
yeah.
Yes, sir.
So
Yes,
they
sir.
will,
They are in the
yeah,
second year midway, sir. Yes, sir.
midway, yeah. So that's why they will experience what today, what we have to read more and what type of questions are asked. So they will mature by the time they appear for the exam.
Yes, sir. Yes,
So
sir. Yes, sir.
this will definitely help them that, and it will increase their confidence for their final exams also. And maybe both these can be given an opportunity again after 4 or 6 months. So they will
We
give
will, sir. We will give
get a more
opportunity.
they will feel more happy and more confident then.
Certainly, sir.
No,
Certainly.
I think
Point
the
is
best way to present or to learn is to go back and look at the videos which have been done before.
Yeah.
You get a
Right.
trend, you get an idea of how things are presented and how questions are asked and how to answer them. And there are numerous videos on YouTube. We didn't have that. They have this advantage. So
Yes.
they should just go back and do it rather than present it clumsily, and they've got a
maybe I
big
will
advantage.
encourage them whenever they are sending the PPT. First thing I
Yeah.
will tell is you take time off to just listen to the earlier presentations.
Earlier.
So that will help them to improve
So,
upon. That is a good suggestion, sir. I will,
yeah.
because I get the PPTs 1 or 2 days earlier only. But even then, if they could go through the YouTube channel, listen 2, 3 full cases, then I think Muthubadevi is back here,
Yes,
sir.
What do you see here?
You can switch on the video, ma. If you are not able to see the slides, it's okay.
I think somebody needs to unmute her. She's
No, ma'am. They are.
saying,
Let me check.
kindly
Let
allow
me
me
check.
to unmute.
There is no setting which is making them to not to unmute.
Yeah, she's unmuted. No, she's muted. She should unmute herself directly.
It's not allowing to unmute.
Some reason.
So can you do it?
Sir,
Dr.
I have
Kanaga.
given twice or thrice the request to unmute from my side, sir.
Okay.
Not sure. I think, Anandi ma'am, you can start giving the closing comments, ma'am.
I think we can call it a day now.
Yeah.
Yes, sir. I think she's here.
Sorry, sir.
You are able to hear us well?
Yes, sir.
Okay. Faculty, maybe we can give few closing questions and then call it a day, sir, please.
Yeah. So we go by your clinical findings, and we
Sorry,
think
ma'am.
you're dealing with a case of multinodular goiter with no features of compression and no evidence of malignancy, and that she's clinically and biochemically euthyroid on investigations. Right? How will you manage her?
We did a surgery, total thyroidectomy, ma'am.
How will you manage her? Would you want to? She's a case of multinodular goiter. How will you manage her now?
We did a thyroid function test, ma'am. Ultrasound,
I told you
FNAC.
she's clinically and biochemically euthyroid.
Yes, ma'am.
Is
Yes,
there
ma'am.
an alternate to surgery?
Yes, sir.
What?
In multinodular goiter, surgery is the best option, sir.
Very good.
Correct. So there's nothing, you got to go in for surgery. Now, what
Yes,
kind
sir.
of surgery?
Total thyroidectomy, sir.
Why total?
In multinodular goiter, the nodules are already mostly inactive follicles are there. Active follicles are yes.
So
No
what
need.
if we leave some of it behind? What will happen? What if we leave some of the thyroid tissue behind?
There is thyroid failure.
Failure?
No. Why should thyroid failure
There
happen?
is
If
no
we leave thyroid behind?
If we left behind, it may progress again, or it may turn into a malignancy.
No,
Later.
Look. Hyperthyroid is difficult to manage, easy to diagnose. Hypothyroid is difficult to diagnose, easy to manage. Right?
Yes, sir.
So now you tell me, why do you want to do a total thyroidectomy and not leave something behind?
If again a goiter developed, the resurgery is difficult.
Very good. So there's no alternative to surgery. And why do you want to leave something behind so that you leave a chance for it to reoccur and then go back and do surgery? So you got to do one surgery, right?
Yes.
Right. That's it.
So multinodular goiter is usually iodine deficiency goiter.
Yeah.
So can you give iodine to treat it? Can you give iodine by mouth and say that now we can treat it with iodine deficiency goiter?
Ma'am, if it is in diffuse hyperplastic stage, then it is a reversible, ma'am. But if already the multinodular goiter developed,
What is the harm of using iodine as a therapeutic measure for iodine deficiency goiter? Any harms because of that? There is this thyroid release phenomenon that can happen if you give iodine, right?
Yes.
So that is why it should not be given. And another reason is that there are some people who are of the viewpoint that it can induce malignancy. So that is why people avoid giving iodine as therapeutic measure for it. Yeah.
Okay.
Well done. But then you must read your books, clinical science, if you're not able to demonstrate, that does not reflect well. So you must read your clinical methods.
Okay.
Hemant sir, any comments
Yeah.
before we
Yes.
close?
Yeah.
Ajay Kannan sir, any comments from your side, sir? I think sir is clear. Sir is there. Kanna sir? I think sir is clear. Dr. Muthu, you have any doubts to be clarified, ma? Do you have any doubts to be clarified, ma?
By today's presentation, I have take home messages. I have to study more basic.
Yeah.
things.
No, Dr. Muthu, that's fine. Go back and see these videos. Right? There are numerous videos on this, on multinodular goiter. Just go back and have a look at them. How did others present? What were the questions asked? What were the answers? Right? That's the best way to prepare.
So you read about sonology in thyroid, right? What do thyroid nodules look like? What do malignant lymph nodes look like on ultrasound? And read about the Bethesda system of
Yes, ma'am.
cytological grading.
Yes, ma'am.
Are you aware of it?
Yes, ma'am.
Yeah.
Thank you, ma'am. Thank you, Muthu, and thank you, Dr. Rishabh, for joining us. And I thank Ratna ma'am, Anandi ma'am, Hemant sir for joining us this thing. And our own faculty, Rajiv sir, Jailal sir, Kanna sir. I think we have the other faculty being assembled in Kanyakumari for a teaching program. So Shanai sir and Srinivasan sir have sent a private message that they could not join. So we look forward for next week for yet another presentation. Thank you very much. And with the permission of the
Right.
faculty, we call the session a close.
Good night, everyone.
Good night.
Good night. Good night, everyone.
Good night,
Good night.
everybody. Thank you for the invites.
Good night. Thank you, ma'am. Thank you.
Trying to log out.